meetings of the General Assembly and its legislative committees during an emergency. This public body is authorized to meet virtually. Please note that there is no physical location to observe and listen contemporaneously to this meeting, which was authorized pursuant to HCR 85. We're utilizing Zoom webinar for this virtual meeting. All members of the Health and Welfare Subcommittee have the ability to communicate contemporaneously during this meeting through this platform. And the public has access to contemporaneously to communicate contemporaneously during the meeting through this platform. Oh, I'm sorry. I just said the same thing twice. And the public has access to contemporaneously listen and participate in this meeting by registering via the meeting link that is posted on the General Assembly's website. The public has access to watch and listen to this meeting through live stream, available on YouTube. A link to the live stream can be located on the General Assembly's website or by searching for the Delaware General Assembly YouTube channel. Should any subcommittee member experience technical difficulties during this meeting, please call 302-415-4433. Public comment is permitted at the close of this meeting. Public attendees in the Zoom webinar must utilize the raise hand function to be permitted to speak and shall be called on in the order in which their hands were raised. Members of the public will be unmuted and informed that they've been allotted 2 minutes to speak. Public comments can also be submitted in advance of and up to 24 hours after this meeting by emailing africanamericantaskforce@delaware.gov. In the event that the public is unable to access the meeting will be adjourned and rescheduled. Please note that any votes that may be taken during this meeting shall be done by roll call vote. Let's begin today's meeting by taking a roll call attendance of the subcommittee members present. Subcommittee members shall ensure that their cameras remain on for the entirety of the meeting to the best of your ability. When your name is called, please unmute your device and affirm your attendance. Once you've been recorded as present, please mute your device for the duration of the roll call. So we'll go ahead and take roll. I don't know, can anyone else tell that that was the last time I'd be reading that script? My goodness. I should have had Rep. Johnson read it. All right, can we have...
I can read a roll if you need.
I'm sorry, Chelsea?
I can read the names if you need.
Sure, because
okay.
I don't see the PowerPoint.
Yes, we don't have slides for today. We just have the list of recommendations.
All right, sounds good.
Nikisha Bailey, Treasurer Colleen Davis.
Yep.
Okay. Keith Hunt, Forrest Watson.
Forrest
is here.
Present.
Thank you. Cassandra Codes Johnson.
Present.
Deb Harrington.
Present.
Simone Philpotts. Eleanor Kiesel.
Present.
Carmen Jordan Cox.
Present.
Ray Jones Avery. Kathy McGinnis. Lucretia Young. Representative Johnson.
Present.
Representative Minor Brown.
Present.
Thank you. And we have a quorum.
Great. With the quorum being present, each subcommittee member's identity has been authenticated. So we're going to just move on to the agenda. And we don't have slides today, but we do have 2 recommendations that we're going to review. Representative Johnson, actually, you know what? Maybe Representative Harrington. Representative, I was about to say it again.
Big it.
Say the third time.
If you do it the third time, it's gonna happen.
Debbie Harrington, you did send in some recommendations.
Yes. Yeah, I did.
Don't we need to approve the minutes?
I was literally getting ready to say before we do that, everyone should have received a copy of the minutes in their email. And reviewed. If there are any corrections or edits, please mention that now. If not, if we could entertain a motion. Carmen?
So moved.
Second by Representative Johnson. Thank you. And now we will move forward with the recommendation. Chelsea, could you throw that? Oh, wait, we got to go through the roll call again. This is the last meeting, and I'm a little thrown off. All right, so we're going to go through this roll call again for the acceptance of the minutes from our last meeting. My apologies.
Right. Nikisha Bailey. Treasurer Colleen Davis.
I'm sorry, what? I got distracted for a second. am I saying I'm present here again, or?
No, so this is for the acceptance of the meeting minutes.
Yes, I accept, yes.
Thank
Okay.
you. Keith Hunt. Forrest Watson.
I accept.
Cassandra Coates Johnson.
Accepted.
Deb Harrington.
Accepted.
Simone Philpotts. Eleanor Kiesel.
I think I have to abstain because I think I missed the last meeting.
Carmen Jordan Cox.
Accept.
Ray Jones Avery. Kathy McGinnis. Lucretia Young. Representative Johnson.
Yes.
Representative Minor Brown.
Yes.
Okay.
All right. So let's move forward to the recommendations. Dr. Carmen Jordan Cox, your hand is up. Is it still up, or did you have a comment?
No, that was to remind you about the minutes. I will take my hand down.
Okay. All right. So this recommendation came from Training and Education. I'm going to go ahead and read it. Let's see. Actually, I wonder if I should have Debbie Harrington just go ahead and take the floor. You want to go ahead and
Okay, yeah, sure. Yep, sure will. Okay. We had two in Training and Education. We came up with our two recommendations. The first is a policy recommendation, and the second one is a legislative recommendation. So let me talk about the policy recommendation. It's really to create an annual forum where these groups partner to ensure that we are educating the public, the providers, and all of the partners. And so we wrote it and educate them in a myriad of things. So we wrote it, and I'll just read it, and we can sort of talk about it or reword it however we need to. But the first one is to create an educational and informational. I can't see it because it's I believe it's part. There you go. Create an educational and informational partnership between DHSS, Delaware Hospital Systems, colleges, universities, and community nonprofit health and welfare providers that establishes an ongoing collaborative forum focused on sharing systemic analysis and data-driven information and solutions towards systematically reducing healthcare disparities and health-related diseases that persist in communities of color. And then it has parts to that. The first being educate communities on minority healthcare disparities such as mental health, prenatal care, diabetes, hypertension, and other diseases. Conduct systemic trauma root cause analyses, food insecurity, access to healthcare, post-traumatic stress syndrome, and racism. Create solutions that allow Medicaid behavioral health funding to provide trauma-informed behavioral health support within public assistance and programs to improve health and economic security. Then seek opportunities to support community coalitions, racial equity initiatives, and action organizations that are run specifically by people of color. And then the last one in this policy recommendation is to design cultural competency programs to educate and train healthcare staff. So I'll stop here and see if there are any questions or discussion or however you want to add to this before I go on to the second recommendation.
Thanks, Debbie. I'd like to hear from the committee members if there are any thoughts or questions in reference to this policy recommendation from education and training.
Do we vote on each one of them separately?
To me, it appears to be one full recommendation.
Okay, thank you.
Yeah, it is one recommendation. Mm-hmm.
Any thoughts from committee members?
I mean, it's just a lot packed in here, right? Into this one recommendation. For me, it would be hard to vote on it just as one, because the A, B, C, D, and E, some of them are very different, affect different parts of the systems.
So I think that, well, we looked at this and it has those parts, because remember, the overall recommendation is that you create a forum, an annual, semi-annual, however often it happens, but that you have a consistent forum that looks at all of these things. That's the purpose. So it's not just one and done. So, and we want that forum to be made up of, representation from DHSS with our hospital systems and, our universities and colleges, the healthcare community, the entire healthcare community, where they can come together and talk about the education and training that's needed to ensure that we do reduce the overall point of this is to reduce the healthcare disparities and the health-related diseases that we find in communities of color. So I personally don't think you can separate those, that A through E, because we're talking about a forum that happens, basically forever and ever, basically.
So I'll jump in. Let me take my hand. I have my hand up. I'll take my hand down now. So Debbie, thank you for submitting the recommendations, and I've read them several times. And Cassandra, thank you for the comment, because that then reminded me, I had already made this up in my head, but I guess it's nice to talk about it. The comment that Cassandra made, when you look at one and then you look at A through E, as it relates to people having a hard time voting on, all of that. In my mind, once we agreed and passed this recommendation, in my mind, I hadn't shared this with you all yet, that when it went to the full body, I or we would be discussing number one as the recommendation to be proposed and passed. A through E are all the ways that you can meet that goal. Therefore, A through E is, hey, these are the examples, but the real recommendation is one. So I would only put forth number one. But in our final document, all of these other pieces are attached to it, because what we don't want is you give the recommendation and someone else later who's implementing this and has to operationalize it really didn't understand where you were coming from, right? So therefore, they began to operationalize this based on their experiences and where they are. A through E provides the framework for what the next steps ought to be. That's how I when I read it and I thought about, because ultimately Rep Minor Brown and I have to, put this to the larger task force. And I'm like, yeah, that could be a lot. Therefore, I would only, I would say number one is our recommendation. Period. We get that done. But when it comes to, the written report and how we get to number one, these are pieces of it.
Right.
Forrest, I see your hand is up.
I can I offer then, because I understood what you were saying. So then what I would just offer an editorial insertion that follows that colon that says EG, and then that would, EG would say, for example, and that would be how you connect that for me.
Okay.
Or you could say, for example, but you can do EG, or you can say, for example, either way.
Yep.
Yeah, I have to say, Rep. Johnson, I agree with the initial policy recommendation to create this collaborative. And then, once we get this beyond the task force, or even in response to any questions that may arise on what this would look like, and what would come out of this collaborative. And that's when we can give these examples of some of the tasks that would be included in this collaborative once it's
Exactly. Yeah, one thing that we learned, I don't know, a few months ago, from another recommendation that we had put forth, it was so detailed that it made it extremely difficult for the group to come to a consensus. And when you're thinking about the recommendations, you have to think high level, but definitely having the 4 examples is the path forward. And considering that the next full body task force meeting that we have is the final one, we don't really have that luxury of coming back to rework as we had in the past.
Yeah, so the good thing is I think we have it. This is what we need. We need this policy recommendation, and we need A through E once we get through the large task force and create some type of legislation to create the collaborative, the group. So
I think you can't, I think, with saying, for an example, and I do understand the points. I think what we were thinking of is we don't want, so whoever goes out and do this, we don't want them to lose the intent. And so we want to give them as someone said, a framework to work from. So that great collaborative, but if it's not going to cover at least these things, of course, we don't want to minimize what it covers, but if it's not going to cover at least these things, then what will it do? And whoever is doing it, will they understand what the intent is fully? So I don't think we could leave that out as just figuring out how you put that in and how you carry that portion forward.
Totally understood, and we definitely won't lose the intent. A through E is not going anywhere.
So then would you want to say, instead of EG, do you want to say to include the following?
Yep.
Yeah.
Mm-hmm.
Yep, that'll be all right.
Yeah.
Would you want me to write that in?
Yes, please, Chelsea.
Okay.
Thank you.
See what that looks like.
Should I say? Does that look good?
Yep. And yeah.
Yep.
Any other questions? Thoughts?
Let's vote on it. Let's keep it
Are
going.
you good? All right. Roll call, please.
Lakeisha Bailey. Treasurer Colleen Davis.
Yep.
Keith Hunt. Forrest Watson.
Accepted.
Cassandra Codes Johnson,
Yes.
Deb Harrington,
Yes.
Simone Philpotts, Eleanor Kiesel,
Yes.
Carmen Jordan Cox,
Yes.
Ray Jones Avery, Kathy McGinnis, Lucretia Young, Representative Johnson,
Yes.
Representative Minor Brown.
Yes.
So that was 8 votes yes. So
Wonderful.
Okay, the second one, Chelsea, if you can move down just a little. Yep. The second one is quick. It's to create a plan to implement. Oh, that's wrong. Sorry, I'm looking at the wrong wrong one. It's a legislative recommendation to mandate cultural competence, equity, unconscious bias, and diversity education and training to be included as an additional core curriculum requirement for healthcare provider licensing and certification spanning medical doctor, nursing, social work, and psychiatric professions. And that's a simple one. There are, and I know because I sit on the Board of Examiners of Psychologists that they had not had they have an ethics requirement, but they didn't have a equity, inclusion, diversity requirement. So for training. So we are recommending that we include that in healthcare providers licensing and certification requirements.
All right, I see Carmen's hand up.
Yep.
Yes. One is I have a question, but first let me make a comment. I would also add to that list, after social work, I'd add psychology, because psychiatry is different from psychology.
Yep.
And so the intent here is if someone's coming from out of state and they completed a program that did not have that, they would have to go and do what?
Take classes and get credit hours in bias, in cultural competence, equity, unconscious bias, and diversity education and training.
And so the assumption would be that somehow the licensing agencies would establish some criteria for what qualified, what kinds of courses would be eligible to meet this requirement.
Right.
Okay.
Yep.
Yeah. Lucretia.
Okay. So should this be more specific to say that it's really these that are listed here? It is the Division of Professional Regulation that renews those licensures and whatever, the mandatory training and CEUs that they have to submit now to maintain their licenses goes through that entity. So is that what we're talking about?
Yes, they do go through that entity, and so they could actually set, they could set the number of hours you additional hours you have to have. What we're saying is that they ought to have that training in their licensing requirement. So just like they have the ethics requirement, they have to have so many credits in ethics education and training. Well, we're saying that in addition to that, you also have to have so many hours in cultural competence, equity, unconscious bias, and diversity education and training.
Okay, I did see Lucretia's hand up. I want to make sure I get her. Lucretia, you're on mute.
Hi, can you hear me?
Yes.
Yeah, hello everybody. It was something trying to sign in today. I'm having some technical difficulties. My question would really be looking at that as a great possibility. What would this look like? I mean, as far as when someone comes into the state who is already trained, when someone comes into the state as bad as most places need healthcare workers, what would it look like? Would it be something that's institutionalized within the organization, like Christiana Care or BB's Hospital, or would it be something that is expected for them to perhaps go to some training at a university? How would this be structured? What would the infrastructure be for them to obtain this additional training? I know there are a lot of trainings that companies go through, because we go through it at AARP, the unbiased and all that training. But I'm just wondering, after someone graduates and comes in here from Ohio, what does that look like to them? Like, what would it be, the institution providing that, or have we any thoughts on that? And have we had conversations with the leaders of the different healthcare institutions about how they could provide that training, or if they wanted to introduce it even? I'm just wondering, is this going to be a win?
Yeah, I don't know that we had a conversation about the actual institutions providing that education and training. We talked about, just as you get your education and training from, we were talking about licensing requirements. So just as you get you go to a university or to some program that gives you the credit hours in ethics training, we're saying do that for this training, for cultural competency training in the same manner. So we did not talk about it from the standpoint of the institutions providing that. That doesn't mean that the institutions can't provide it. It's just that people, when someone comes in to get their licensing, they may get their education from any university in Delaware, or maybe they got their education from outside of Delaware. But what we're saying is that you have to get that education, that you have to add those credit hours to the list of education courses that are required for licensing.
Great. So thank you for that, Debbie, Representative. So I'm thinking that it would have to really be nailed down as far as the methodology here. So do we go to the STAR campus? Do we talk to them about, can you provide that to all of the nursing students and the health students? Is this something that we can just introduce? Can we identify a great training to introduce to them, which would be a simple measure? I mean, my company, ARP, nationwide, we all go through this training every single year as a required training for every staff at ARP. So is that one approach, or would the approach be when you come into our state, or if you move into a healthcare institution or facility, it could be outpatient care, home and community-based services, you need to have this training. And I guess I'm saying that because I love the idea, and I just appreciate the work you're doing. But it is a very, very broad scope when it comes to requiring individuals to go through this training, and there is no infrastructure set up. Right now, we need healthcare workers. We need general physicians. We need nurses. We need doctors. And in Delaware, there's a very small playing field there. How long does it take to get with a specialist? How long does it take how hard are they trying to just recruit nursing students and, nurses that are leaving our state, and medical professionals that are leaving our state, that are learning, really getting good education here in Delaware. So I think we need to look at what is the platform for us to deliver this if we're asking for it. And it's, it can be working with, I'm not a healthcare professional, Lord knows, I respect them, but I'm not. But I do know that the administration and healthcare requires some checks. It does require checks and balances, but there is also a place for the work that you're doing. And so it would behoove us or someone to speak to different institutions and get an idea of how this can work. Because if we just mandate it.
I'm sorry.
After Eleanor, I'd like to jump in. Go ahead, Eleanor.
So let me just say something quickly, please. Lucretia, all really good comments. And I just want to share this, and Debbie, you help me out here. When I think about this, I'm not thinking about how to operationalize it at those levels that Lucretia just discussed. I'm looking at it as a legislative recommendation that goes directly to the licensing board. It is, I think the broadness of it is good, because then when the licensing boards have to institutionalize this after legislation has been passed, it gives them the flexibility to do what they need to do to get it done.
Yes.
So I wanted to kind of put that out into the universe. Like, we're not coming up with, I'm sorry.
Thank you for that. Thank you for that explanation, because it's really about how are the regs going to be set up, who's going to be responsible for this, like who's going to be watching it and carrying it through, because that's the key piece. We can legislate, but we have to be able to deliver, and there has to be a timeline. And so I appreciate what you're saying. I know, just working with the healthcare institutions nationwide, it is not always easy to get these pieces in place. And I'm willing to help work on it. I think it's a wonderful idea, but I'm just asking. I didn't know if you had thought through the infrastructure for it. So thank you.
So usually what happens is we come up with the recommendation in this committee, right? And then we present it to the task force, the overall task force. And then it's going to be up to Representative Johnson and I to have conversations with DPR, with attorneys, with hospital associations. And I can bring up an idea, a thought popped in my head, right? Something nationally with implicit and explicit bias training related to the maternal mortality epidemic. So after months and months and months of conversations, today, House Bill 344 was filed, which does require that hospital facilities, birthing centers, so on and so forth, ensure that every employee in those facilities has to have an implicit and explicit bias training. That's a piece of legislation that was just filed today. Debbie's taking it a little further, which is really good. And I think it's a great recommendation. But that is when those conversations begin to happen. They're not going to happen in this subcommittee.
Yeah.
Okay.
Because that it gets too technical. We're not bringing DPR in. We're not going to bring our attorneys in. That is a whole. We got to get there.
Yeah.
Got to have the recommendation first.
Yeah, I like what you're saying, and I like this recommendation. I think that coming from the educational piece of it at DSU in Wesley College of Health and Behavioral Sciences, where we have social work, nursing, psychology, and all of those departments. Certainly nursing and psychology are accredited programs. So it's very difficult for us to add courses that could comply with this if this would become legislation. We want our students to be ready from an educational standpoint to do the coursework or the practice hours that they need in order to take a clinical licensing exam, or an LMSW or a licensed BSW. We don't want them to have to take courses after they get a degree. So that's sort of where my issue is with some of this. I mean, for our courses, we have cultural competence. We have a Black perspective running through all of our courses in social work that include an unconscious bias when you're trying to use a conscious use of yourself with clients, right? So you're getting that information, diversity in education. But when it comes to licensing and CEUs, after you're licensed, you only need a 3-credit course over 2 years in ethics.
Right.
There really isn't anything that requires you to continue on with a cultural competence in your practice, or an African-centered approach, or another type of cultural approach in your work. So I would see something like this being more helpful from a CEU standpoint. rather than from the time someone gets their degree to their license. So just as a thought for future reference, I mean, I know that this is not going to become legislation.
No, that's a good thought. Is that to look at it from a continuing education perspective, after they have that is a very good thought. Yeah.
Yeah.
And also for our students, financial aid will only pay for so many credits.
Right.
So we can't just add a 3-credit course.
Right.
Same with nursing, I think their accreditation may even be a little bit more rigid than what social work is. So it's just those kind of considerations.
Right. Yeah. And the Board of Examiners, we just did the one that we just did, that was put in continuing education. We added it to the licensing requirement for psychologists and psychology assistants, but it was in CEUs. Yeah.
Yeah. So I think that's a great idea.
Yeah.
This is Keith. I'd like to weigh in on this.
If I can just say, one more word.
Well, wait a minute. Because hold on a minute. What I want to do is I just want to be respectful of everyone who has their hands up. And Dr. Gordon Cox actually had her hand up after Eleanor, and then I saw Keith's hand. So I just want to go in order so everyone gets an opportunity to speak.
Quick thing, Chelsea, don't forget to add psychology in that recommendation.
Yes. Where do you want me to put it?
After social work and before, after social work.
Sorry.
Yes. What I was going to say pretty much has been said, that a lot of those kinds of logistics would actually get worked out when the legislation is actually being written. So that this is not where we would be working out some of those details. But also, as I've listened to the whole conversation, I want to remind us that while some things may not be convenient to do, we have to remember the reason that we're doing this is because there is a larger problem, that the way we collectively have been training and educating our professionals has led to has resulted in the kind of consequences
that's right
that we're trying to fix. So, that's just a reminder, that some things are not ancillary. And I think we've been dealing with some of these issues as though they're ancillary, so they don't get addressed.
Right.
Thank you. Keith Hunt.
I have to say, with Carmen Jordan Cox comment, I take my hand down because she's right on with what I wanted to make comment about.
Okay, thank you. And Lucretia.
Yeah, I wanted to say that I support the work. My concern is always how will it be, how will it roll out? So, and when I talk about different institutions, I appreciate the lady prior to me who spoke about should it be part of a credit or how will it happen after someone gets their degree. So I would even say requiring every health institution to have the training. I mean, we take the training in my organization in a couple of days. Everyone has to do it from, I don't care if you're a custodian worker in Washington for AARP on up. We all have to take the training. It is mandatory every single year that we do the unbiased training. And so perhaps the place to really to put the onus on would be the hospitals and the health organizations just to provide that training, and everyone has to take it every year. You don't have to you can get credit or not, but it's necessary for it to occur. And that was my thoughts.
That's a great thought. The only thing is, I kind of just tackled that. We just did that with Health 344. So the folks that work in the hospital, the healthcare institutions, even down to the housekeepers are required to receive that training. And it is as for the licensed individuals, it is as CEUs, and for the non-licensed, it is a yearly training. But there are people who don't work in healthcare facilities, and we still have to make sure that those individuals are receiving that same training, which when we talk about these individuals in the recommendation who actually carry some type of certification, then that is when we probably just need to look into the CEUs, because, you know, they may not be working in a healthcare institution. If someone works on an ACT team, you know, they may not, you know, they would slip through the cracks.
Yeah.
Debbie, I was wondering if you wanted to include the portion about continuing education credits, or you.
Well, I'm sitting here kind of thinking, and Carmen said it, kind of my summary thought, is that, you know, all these months, we've been talking about the disparities that exist and how do we get rid of all of the things that are hindering our communities of color. And sometimes that's going to require, you know, taking the hard road. And so we could say continuing education, but do we start with those who are starting out as students, and they're going to end up being, you know, providers? Do we start right there in that period where we are able to influence their learning early on, so that they come into the profession with a deeper understanding of some issues that are deep-seated? And so I don't know that we want to limit it to continuing education units. Really, I think that we should have our universities, particularly here in Delaware, but have our universities offer these courses, offer these programs, in not just Delaware State, but all of our universities. And
weave it into the existing curriculum.
Put it in there.
A special course.
Yeah, or put it in, but they are required to do it. I don't think we miss the opportunity of starting early, so that when they come into the practice, they have a better understanding of the people they serve.
So Debbie, would that better fit in one of the tasks of the collaborative, for them to create or work towards creating or improving their curriculum, or introducing this type of education in their curriculums of Delaware schools, you know, in the Delaware college curriculums?
I think that for certain we could add for them to implement it in their curriculums. We can definitely put it in number one. There's no question about it.
Because in number one, the schools are at the table already.
Yes, they are. Yeah.
We could probably work together to create that curriculum.
But it still ought to stay in too.
Yeah.
Mm-hmm.
Both places.
So I think your question
can it stay in two? That's my question, because would that be two separate recommendations? You know, like if we're gonna mandate implicit bias training for licensed professionals to receive or be mandated to complete when it's time for them to renew their licensure, that's a recommendation. And then to mandate that our Delaware higher education institutions include a cultural competency or unconscious bias training, or whatever you want to call it, in their curriculum. That's a separate.
That's true. That's true.
Yeah. Yeah.
And that, you know, so.
Yeah.
Yeah, those are different things.
Yeah. And one you could do right away, one you're going to have to do over time. So I think you're right that's maybe two different ones.
Oh, well, this, if I may, this number two hits a nail on the head in terms of the providers, the practitioners, and have the expectation that they get this training as part of their normative process. So if we create a separate one, that's fine, but this one should remain intact because it hits directly at the providers.
And that was what I meant that was what I was getting at too. I agree with you.
But then this one we would be saying, that we'll be talking about continuing education.
Well, I like your comment about the continuing education. To me, at this point in the process, why box ourselves into framing it around CEUs as opposed to just putting it out there as it is, and then let the details of how we implement it and where it gets applied work itself out through the discussion of the legislative process.
Correct.
I only say that because you could say right now to those licensing boards for continuing education, you have to require this. But if you want the universities to include it in the curriculum, in their curriculum, it requires that's a process.
But in order for this to get to the legislature, believe me, there will be thousands of hands, or hundreds of hands, and lots of wordsmithing of this before it ever gets on the floor. Mm-hmm. So all of those things, I mean, all those things will be considered. There's lots to go on before this ever gets to ever sees the light of day. So I think that there are many opportunities to clean up the language, to think about. For us, it's a broader issue that we're trying to put on the floor right now. And then I think the legislative process will help to sort out whether it should be CEUs, how many of them there should be,
right, yeah,
and all of that.
Yeah.
And you could probably change the wording somehow by saying, mandate cultural competence, equity, unconscious bias, and diversity education and training, to be included in higher education institutions, curriculums, as well as through continuing education credits once certified.
But I feel like you could do that, but I feel like that tends to in some ways water this down because it broadens it so wide and deep to include everything and everybody in the kitchen sink. At the end of the day, to me, what we want is that the practitioners that get licensed in the state of Delaware, whether they come from Alaska or wherever, but they get their license in the state of Delaware and can keep their license, have this training.
They have to have that training.
I mean, and I would say that if it never gets into the higher education curriculum, I can live with that. I would rather live with that than live with this continuing to be the way it is, with people having disparate treatment. I don't know why. I can do it over here, but I can't do it over there. I'm stupid. I'm tired of the conversation about it.
I agree.
I think Forrest has his hand up.
Forrest.
Yeah, I was trying to understand the focal point of because when I see core curriculum, that to me means the education at an institution that leads to a degree. That's what that says to me. And it really doesn't say CEUs, but I believe CEUs need to be done as well. I think it's an ongoing developmental awareness of what it means to be a human being in a diverse community. I think that's ongoing. I don't think you can get that one time and be done with it. So I really don't. So I think that should be part of the CEU, but I do agree that as part of a core curriculum education, I don't think we need to keep turning out individuals who are blind to this. I mean, it's clear in most places that, from my understanding, it's clear that individuals can get degrees with no interaction of what it means to deliver any kind of care or be educated about anything in a diverse, multiracial community. You can get a degree and not have any idea about that, and that's ridiculous. So that's ridiculous. So I know we need to stop that. But then on the opposite side of that, as we learn what it means, I mean, for instance, unconscious bias wasn't something I used back 30 years ago. I mean, we didn't know nothing about that. I mean, it was just straight out, you was racist. In my mind.
And then
So-
microaggressions and things like that. Most people don't know what microaggressions are.
Exactly. So what I'm saying is that's why we need the continuing education units to help people understand, because people don't realize that what microaggressions, to your point, as part of the kind of fabric that other communities of colors are up against. They think when you start talking about this, they're thinking, okay, I have to have a Hitler's cross. I got to be burning, a cross in your yard, or I've got to have a hood. That's the only way that these kinds of systems can be perpetuated, because it's a moral choice of indiscretion. That's what people believe. And that's not what is happening. And so on one side, we need to include it in the curriculums to make it as part of the fabric of how you can be a provider in today's multiracial and multicultural society. And two, how you can continuously improve the level of your awareness and being a better human being. And so I don't know how, so I'm saying that's the focus, and let the folk figure out how to do those two things. But one is inclusion and one is continuous understanding and getting better. That's what I think. And I think you need to tie it to a renewal of license.
So if we do that, then we would take out the additional core curriculum, because what we're saying is that should be a part of the core curriculum, and then it should be a part of the continuing education curriculum. So maybe it's included as a core curriculum requirement. And then somehow we have to put in there what is the continuing education.
And what you could do as well as continuing.
Yeah. Included as a core curriculum requirement, as well as continuing, or included as a core curriculum or in the core curriculum, as well as continuing education requirement.
Chelsea, you there?
Yes, I am. What would you like me to write?
So after, okay, you see what included as. Go ahead, Debbie.
So am I breaking?
Go to the second line. Go to the second line. No, not creating a new one. Okay, go.
Number two,
second line.
After the word included.
Right there. Yeah.
Okay.
Included as a, take the N off of that, a, then take out and additional.
Included as a core
curriculum. All right, wait a minute. No, included in the.
No, you could leave it as a core curriculum, and then you could do as well as.
Requirement for healthcare provider thing, and then after this say as well as.
No.
It's a requirement.
We're still up after the word requirement.
Okay, as well as.
Yeah, there you go.
Continuing ed credits, is that what you mean?
Continuing credits, yeah. Continuing education credits, yeah. Yeah, okay.
For licensing.
Licensing and certification. Yeah.
For licensing
and renewal.
Yeah, licensing
and renewals.
Renewal and certification.
No.
I know.
Yeah. All right. Go back up to the next that line right above it. Put a comma behind licensing. And take that
well, healthcare needs to be back in front of licensing.
No. Yeah. Okay. Right where you are, to take the comma out. Take the comma right where you put that. Okay. Healthcare. Put healthcare right there.
Healthcare provider.
Healthcare provider licensing.
Mm-hmm.
Okay.
Okay. Licensing.
Comma.
Behind licensing, put a comma. No, behind license.
Behind?
licensing.
Oh, after, okay, I'm sorry.
Yeah. Okay, take and out.
Okay. Licensing.
Renewal
And good.
and certification. And put it,
And then we need to take out that second.
yeah, take out that, yeah, for healthcare provider right there, where you take.
Take out
this one.
Or help, right,
Right.
yes.
Keep going. Take out certifications also.
Okay. Take
That's
all that out.
Yes,
Okay.
take out 4.
There you go.
Okay, there it is, all right.
Thank you. I apologize for the.
Oh, no, you're
Oh,
fine,
that's
you're
fine.
fine, you're fine.
Chelsea, you did well considering you had 3 different people talking to you at once, okay?
You did good. She
Really?
did very good.
The only thing is that you've included continuing core curriculum requirements as well as continuing education credits for healthcare provider licensing. So you're saying then that a social worker is a healthcare provider, a psychologist is a healthcare provider? I don't know that I'd put healthcare provider there. I would just put continuing education credits for licensing, renewal, and certification.
That's true. It's not necessary to put healthcare provider if we're listing the occupations.
Because you're talking about a medical doctor, a nurse. I'm assuming that within nurse, you would have, your nurse practitioners or physician's assistant.
Well, you would not have a physician's assistant because they don't fall under either of those categories.
Right, so you might want to add that.
Are they licensed?
Yes.
Yeah.
Should I take this out?
Yeah, take
Yes.
that out, Chelsea.
Is there a broad category of like nurse license?
Well, there is where your healthcare providers are, right? Your healthcare providers are medical doctors, nurses, nurse practitioners, physician's assistants, right?
Mm-hmm.
Unless you want to get explicit, then just add physician's assistant.
You after nurse, you after nursing you can do a parenthetical after, you can put nursing professionals and do a parenthetical.
Because I think you're not capturing a whole lot of healthcare providers if you're talking about radiologists,
Okay, why don't you do what? We could.
No, that's
licensed healthcare professionals.
Professionals, yeah. Licensed healthcare professional.
Including but not limited to.
Or you could have all those specific categories and then put at the end and other licensed healthcare professionals.
Right.
And that catches everybody. So after psychology, put a comma and take away the and then then put an and after. Do we need to say psychiatric to after professions? Put and other licensed healthcare professionals.
Okay.
Does that work? Does that catch everybody?
Yeah, I don't know.
If this is going out for discussion, people, if we've missed something, I would think that, there would be people that know more, or not necessarily know more about healthcare professions, but be able to catch something. I don't know, as we were saying earlier, that this has to be the etched in stone recommendation, right?
I agree. I think it captures most of it. And
we've got some parallel. We have some parallel construction issues with our English, but anyway, but I think we made the point.
I think so. The license.
I think you got it. I think you're getting everybody with that and other. It's like in other duties as assigned.
That's right. This is our version of et cetera.
Yeah. That was a
Well,
flashback.
as somebody mentioned earlier, we don't have to burden ourselves with writing the legislation here and now today, as much as putting it in the right direction and then sorting it out as we proceed. So I think other license gets us there.
Agreed. Lucretia has her hand up.
Yeah, so thank you for this information. I'm real excited and pleased that you're moving in this direction. My only recommendation would be to encourage the language to include all healthcare workers. One of the biggest challenges we have with 39 million members nationwide, and I have 189,000 in Delaware, is just general everyday care that they get. And the biases as being African-American or Black are huge. So it can be someone who comes and turns you over every 2 hours at night. It could just be a helper. They may not be licensed per se, but we have a huge challenge in our country with the way, and I'm just going to be very, very blunt, Black people are treated in healthcare facilities and home and community-based services. So I don't care if you're an aide who goes to, I took care of my mother until she died for months. And I don't care, and I went through it. I don't care if you're an aide who goes to someone's home. You have to understand biases. You have to understand, you have to take the time to listen to people, regardless of their race. And this is a huge issue. And so it's not just licensed professionals. And that's why I'm saying, that's the only reason I talked about the infrastructure, though I do understand and respect what you're saying about someone else will set that up. It has to be set up so that anyone handling minorities, people of different cultures, are socially responsible. This is a huge issue. I mean, AARP, literally, we sue nursing homes across the country. You may know that, right? And I can't talk about all. I mean, what we find is appalling how people are being treated. And so it's, and then there's a disparity in the number of African Americans, Blacks going into nursing homes. It's a huge disparity because they're going into nursing homes because they can't age in their house. Very simple things. And so the number is huge. And so all I'm asking, and the reason I've asked about the infrastructure and Representative Minor Brown, I'm just excited to see this work. It's the first, like I've been in Delaware, like when I moved to Delaware sometime, I have never seen this type of work taking place. And so I won't talk about the work I did before, but I'm excited to see the work. My only concern is, do we have a handle on the fact that it is not just people with degrees? That a lot of people with degrees know better. They want to keep their jobs. It is the everyday people that handle people that are biased. Not that people with degrees aren't biased, but there are more people out there that are turning over our family members every 2 hours, like they did with my mother, every 2 hours at night, that do not have this training. So what is the deliverable? Does every healthcare facility or every health aid organization need to have a training? And that's, I'll leave it at that. But it's not always the doctors and the nurses, because sometimes they have become so, they're quite often sentimental because they have patients. But the person who comes in at night to bring the tray, and my mother was in rehabilitation, and the guy, he didn't know I was walking in, and he like snapped on her. She was dying. And he snapped and screamed at her. And I won't go into what the fear and the trauma it put into her, but we need to make sure that everybody who is handling anybody has a cultural relevant training.
Yeah.
And I don't have no problem with people getting credits for this, the social workers, the psychologists, like my sister is a psychologist at Lebanon Valley Hospital for Veterans. That's what she does for a living. And so I get it. But it's the everyday worker that is often a challenge.
Can we just put licensed or unlicensed?
Can we just make that I would make that a second recommendation under second legislative recommendation. I wouldn't commingle them. They'll get all messy.
It has to be separate. It has to be separate. Now, when you talk about the nurse's aide, that falls under this because nurses' aides have to renew their license and they have to get CEUs. But
I love that. Yep.
When you're talking, now we're talking about
technicians,
entities such as 344 is hospitals and birthing centers. So another recommendation could say healthcare facilities, and all staff that work in a healthcare facility receive this yearly training that the facility is required to provide to the employee. But it does have to be separate.
Right. So take the first part of that.
I agree.
Take the first part of that recommendation, duplicate mandate, start the word mandate and go to the word training. Make a second recommendation and just copy that.
Yeah, copy that.
No, they doesn't become three. So now legislative recommendation has an A and a B. So A,
are they two separate ones now? So
okay, I'm sorry. Okay,
so that's right. Three.
You're
yeah.
right.
Yeah.
So call that. So okay, make that. So then whatever the target group would be. So if we want annual
facilities,
mandate annual, is that what we want to do? Or just mandate?
I think it should be annual. I think it should be annual.
After the word mandate, put annual. And then our target, what's the broad category for our target group?
For healthcare workers?
Healthcare workers.
Workers. Yeah.
Or volunteers. Hospitals have tens of thousands of volunteers working with patients every day.
I think it should say for all individuals that are working in the healthcare facility.
Serving patients or something in healthcare facilities.
Perfect. Yes. Yeah. So that's the infrastructure we're trying to bring up when it comes to understanding cultural competency.
So do we want to have unlicensed, since we referred to licensed one in the first, well, these are the unlicensed individuals?
Is this correct so far?
Yes.
Should I write facility? Is there anything I should change? In healthcare facilities or just in healthcare? Is there anything
facilities?
Yeah.
Facilities?
So, okay. But I thought you talking about home healthcare, So when we say healthcare facilities, it does not include the home healthcare aides.
Well, the home healthcare aides
are coming from.
Why not just leave it as healthcare? Period after healthcare.
I'd take out
the aides that are going out to someone's home still have to renew their licensure. They fall under number one or number two. Okay.
Yeah.
And in addition to that, if you're not a CNA, oftentimes these agencies have training. And so that training is provided to their staff, who be a CNA or a direct support professional who's going out to someone's home. And I will tell you, having spent my entire career in human services, a lot of providers already have this type of training, and it is mandated by the individuals, the entities that they have their contracts with. And in addition to that, if you have specialized accreditation, for example, CARF accreditation, there is a portion in CARF that mandates you must have cultural competency training, because if you do not, that's problematic. So I wanted to add that. I wanted to say several things, guys. Sorry. While the conversation has been great and we've come up with a second recommendation. I think we need to move to be very focused so that we can begin to vote. We only have a half hour left and we still have a number of recommendations to flush through.
Two quick things. One, can we change individuals that to individuals who, so it's grammatically correct?
Yeah.
Thank you. And do we want to refer to them as unlicensed? To distinguish them from the ones who have to be licensed? Or non-licensed, as opposed to unlicensed or whatever?
I think I would leave it blank because I think you're going to capture the most amount of people that way. Because there might be something we don't know about, like some type of certification that's not a license or, you know, that sort of thing. I would try to keep it as broad as possible.
And I would just say, as far as healthcare facilities, we want to talk about home and community-based services. Most people want to age and die at home. And so home and community-based services are actually cheaper than being in a nursing home or a hospital. And so I think we have healthcare facilities and HCBS, home and community-based services. That's huge. That's where a lot of our tax dollars go. And so
But don't they have to be licensed? Isn't that what Cassandra was saying, that the home healthcare are licensed?
So the home-based, the HBCUs, they too will oftentimes fall under a category of some type of provider. And that provider then sends the staff to the individual's homes. They too are responsible for providing training to their staff. Home and community-based services will capture all of those people, regardless of what their titles are.
So would they
and recently,
would they be covered under number one, under the prior one?
So I think we just leave them at 3. I think Chelsea we should have it on this number 3, home and community, to add that home and community-based services. Completely covered.
Would you be able to repeat it one more time so I can make sure I have it correct? Healthcare facilities and home and community-based
Services.
Services? Okay.
Yeah, services.
Yeah, that covers a lot of things. That covers a lot of things.
Call for vote?
Yes, it's time, please. Thank you.
Yep, roll call.
So is this voting? This is voting for the second recommendation and the third now.
Oh, so before the third one, why don't you put add again, legislative recommendation right there in all caps and a colon. And then aren't we voting on the whole package? Is that what we're doing? We're voting on all 3 of those?
I think we should, for the sake of time, considering we have reworked each and every last one of them as we've talked them through, and we did not move on until we had reached a consensus. So I think we need to just go ahead and move along, guys. It's 7:01.
Agreed.
So number 1 is passed already. So
okay.
It's 1, 2, and 3.
Yeah.
So moved.
Okay. Nikki Trinelli. Treasurer Colleen Davis.
I approve.
Keith Hunt.
Yes, yay.
Forrest Watson.
Approve.
Cassandra Codes Johnson.
Yes.
Deb Harrington.
Yes.
Simone Philpotts. Eleanor Kiesel.
Accept, yes.
Carmen Jordan Cox.
Yes.
Ray Jones Avery. Kathy McGinnis. Lucretia Young.
Yes.
Representative Minor Brown.
Yes.
Representative Kendra Johnson.
Yes.
Okay. So they pass.
All right, let's move on.
Right.
Down that we have a little less than a half hour and we have to end on time. Okay, so last week we discussed behavioral health and we got through one of the recommendations, but there were still a few others. We did say that we would go back and reword, the first recommendation, which we did do. So I'll just read that. Actually, this one was already voted on though, but it was to create a plan to implement a school-based wellness center in every elementary and middle school that utilizes a universal screening model to address students' physical, social, emotional, and behavioral health needs. And as an interim step, the implementation plan should expand the eligibility in existing school-based wellness centers to students' siblings who attend school in the same district. What are these? Okay, so.
I had a question about the first one.
Yes.
So it says every elementary, are we referring to public, private, charter? Do we need to clarify this?
I will leave that up to.
And do we have the capacity, do we have the ability to require that in public, private? I mean, I didn't know what the.
Carmen, I'm gonna yell at you because that could have been a question at the last meeting. And now
we had lots of other things around this at the last meeting. So.
All right. Forrest, please wait.
Can we leave that for the discussion later?
Well, the question is, what is the intent?
I think
I would think the intent is
research on how that would look and where that money would come from, in reference to public versus charter versus private, who would fund this wellness center. I think there's a lot that would have to be involved, but I don't want to speak ahead because I don't know.
But private schools, I mean, there are just so many different sides. I don't know why we wouldn't just be talking about public schools in this case.
And that's my understanding, that because, you know, public schools are funded by state money, period. And we often mandate to them what they can and cannot do. When it comes to charters and privates, we're walking a straight line. You know,
I assume that we meant public, but so if that's what we mean, then that's what we should say. And that kind of relates to my second question, because last time we talked about this is already being done in public, in the high schools. Is that correct? They already have wellness centers? That means the public high schools have wellness centers, correct?
Right.
And we know that.
Go ahead, I'm sorry.
We know that for a fact that the public ones have it, right?
Hey guys.
I know they do. I don't know if they all do.
What I'm going to ask is that, listen, I want us to move on because we voted on this one already.
Yeah.
And I want us to move on because we have a lot to get through, and it's 7:06, and this is our last meeting.
Yeah.
So if we just made this language say all public elementary, middle, and high schools, then that would cover everything. That would not leave anybody out, because that's really our intent, isn't it?
Well, let's talk to the person who recommended it, because I know that there was a reason why you focused on elementary and middle.
Because they said because high schools were already covered, but if we're not sure that all the high schools are covered, then adding them in, if they were left out because someone thought they were already covered, then add them in shouldn't be.
Already, I want us to move on.
Yeah.
We will have to come back later, but we have to move on. This is our last meeting, and it's not fair to the person who sent the recommendations that we don't continue. Okay, this is where we got stuck. Go back up, Charles. Let's see here. Okay. Go up one more. Let's see. The recommendation for behavioral health is very narrow, and the group may want to consider broader recommendations, some of which are included in the Delaware Behavioral Health Consortium work. All right, go back down. Rep. Johnson, you're probably just as stuck as I am as we try to figure out things like implementing. Okay, these are actually, okay. These are Caitlin's thoughts, right, Rep. Johnson, am I right?
Yes, and let me minimize. I'm multitasking because we actually had somebody else. One of our only guest here is Connor, who works in Kathy McGinnis's office, our auditor, and she was saying he could have answered some question for us. So I'm trying to multitask. And so Chelsea, when you get a chance, just elevate Connor. So like if he has answers for other things, he can jump in and help us, and maybe it'll stop some of the other chatter. So sorry, Representative Minor Brown, ask me that question again, please. These were the information that we received from Caitlin, yes? Okay, so now she's multitasking.
I am, I'm sorry.
It's an interesting day. That's all I have to say. And I can't, okay. So these are, this is the rework that Caitlin sent to us, yes?
Yes.
Okay. So did we share with them what we asked her to do for us?
No, we did not.
Okay, so listen, guys, and perhaps it will cut down some of the conversation. After the last meeting, you know, we agreed to getting back together to rework the recommendations that Forrest did. You know, keep the intent, but just rework it, because again, we need these recommendations to be approved by the larger task force. So we phoned a friend, okay? And that friend is Caitlin. Caitlin is an expert, and she has helped us throughout this entire process. And she has a keen eye in creating recommendations that speak to the intent that, you know, will not cause other problems. Just get it to the finish line. And so these are the recommendations, the language that she came up with after reworking things for us. Okay. So if, Chelsea, if you can go up, because that's the A, B, C, and D. What was, okay, so number 2, what is this? All right. The recommendation under behavioral health is very narrow, and this group may, okay, I'm confused by that.
That number 2 is not a recommendation at all.
Yeah, exactly.
Just a discussion. Just a bunch of comments.
It's
Right.
a discussion.
I would just
are
like to make one comment. If I can make one comment, and I'm sorry, I know I haven't been in the meeting for a minute and I've gone through a lot lately, but create a plan to implement a school-based wellness center in every elementary and middle school. We have a better chance of this being accepted, and more educators and school administrators and superintendents being receptive to this if we have something like create a plan to implement a school-based wellness center geographically so like a conglomerate. So maybe there's a school-based center set up, because we have a fiscal note on this, right? So maybe there's a school-based center set up in the Smyrna school district that all of like 6 middle schools can use, that can be in charge of providing this, because I think it's a wonderful idea. But I think that to say every single school has to do this, that's going to be a huge fiscal note for any school superintendent. You're going to get a lot of pushback. And
from the taxpayers like me, you're going to get a lot of pushback too.
Pushback. So I'm wondering if we can just change the language. A wellness center within school districts. So maybe the school in the middle of that geographical metropolitan area can have that piece. Maybe they can have a center there, and all the schools in that area can contribute to it, which gives you an opportunity to have something big and robust. And all of the schools are working together on all of the principals. They know that at this one specific place geographically, that's where we're going to have this set up. Or maybe 2 within a school district. Sorry, people are coming in my house right now. I got to shut my door. Maybe 2 within a school district. But for every single school, that's a very large fiscal note for educators and for administrators.
And I think it depends on, you know, how we value these wellness centers and the data that comes out of them. We passed legislation to implement a school-based wellness center in every high needs school in Delaware. And that legislation passed unanimously.
High need, I like it, yeah.
We've seen the work that's been done in these wellness centers, and we also realize that sometimes our kids slip through the cracks when they're not in a, quote, high needs school. And and looking at some of the work that the wellness centers do, and that's where Forrest comes in with the universal screening model, not waiting for the kid to come to the wellness center because they're exhibiting high risk behaviors or red flag behaviors, but working with every child to provide the coping skills groups, the social emotional learning groups, the wraparound services, so on and so forth. I mean, we've seen in elementary school, the very first wellness center, we've seen how behaviors, and Forrest, correct me if I'm wrong, because I know I'm gonna have my numbers wrong, but at Eisenberg Elementary, I want to say 2015, was it? The behavior was like in the thousands.
Yeah, it was,
And
we started off at about 1,200 disciplinary referrals, probably 2015, 2016, down to about 150 or so annually.
1 year of the wellness being placed in the school.
Yeah.
Oh, well, let me just interject for the sake of time.
I just want to.
For the sake of time,
say,
can we just? I think we got directionally intent here, but for the sake of time, I would say the edit would be around, instead of in every, would be in high needs school, some language around high needs school.
Well, and also, I think that it would be great just to say implement a school-based wellness in every elementary. Like, we don't have to put bricks and mortar on this.
Nope.
We can just say in every elementary school. So if the program is designed and managed by two of the schools, they have to go to the other schools. So the setup is that you still go to the other schools to meet with the other students. It doesn't have to be bricks and mortar, a building.
Well, I think that's what we're already doing, if I'm not mistaken, correct? Like, we're not rebuilt. We, like, in the school, when we expanded to 6 additional schools, there was no, the rooms were kind of already there, correct? Well,
okay.
I once again, I gotta take us back again, because we've already voted on this recommendation, and we got to get through.
Yeah, how much further do we have to go? I mean,
it's 7:15. We should go ahead and agree to another meeting right now, because we have a whole other list.
I agree.
We're not going to finish. This is, we can't talk about each one, even though it's valuable talk.
Yeah.
If we can't read this ahead of time and decide whether in theory we agree to this, then, we may as well have 5 more meetings, because we'll never get finished.
I thought we had a deadline, though.
We do have a deadline.
Final.
You know what, Eleanor? I think we agree, but I think it's the methodology that we're sort of stuck on. Like, how does this look?
Yeah, I think so too, but I'm not sure that we need to get to the methodology.
And that was the point I attempted to drive early on. Like, we're getting so far into the weeds of how it's going to happen. We're not here to tell them how, we're here to tell them to do it.
Right.
And with their resources and their expertise, they will figure out how to do it.
Yeah, we would like to have them in all the schools, and then
I can only say that we don't want to set ourselves up for failure either. We want to make sure that these are real possibilities, and that it's not going to be so much, the teachers union because this is real important work.
Well, like I said, and number one, to that point, number one, let's just get to the chase, folks. And number one, changes from every elementary to the high needs schools in each district. So,
well, I think it should be every school.
This is one we already voted on. I don't know how we can change it if we voted on it.
Okay.
I think this platform should be for every school. And like you said, let them figure it out. If they just have 2 schools that actually have the center, but those folks rotate to different schools and they have a room at those schools, I think every school is going to need this. It's so important.
And if we're reopening the issue, then I want to raise the question again about public versus private, since we obviously reopened the conversation.
Yes. So I guess we're gonna have another meeting.
So I'm sorry, but the final African American Task Force meeting to pass recommendations that have come out of specific committees is on April 11th.
I thought so.
And we are given a timeline as to, we have to provide them with recommendations beforehand. So I think this may be the last meeting.
This is it.
Yeah, in order to pass them.
And Chelsea, you'll have to forgive me. I'm so sorry because I got text messages and things coming in. So Connor, we should have elevated Connor much sooner because Connor was the proxy for Kathy, and he wanted to vote on all of the previous recommendations. Chelsea, you just gave a timeline. Can you give that timeline again, please? Because I missed the ending of it.
Yes, so this was the agreed upon final meeting before our final African American Task Force full body meeting on April 11th, because we have to give them a certain amount of time to review the recommendations that are passed out of each subcommittee.
Gotcha. So April 11th is a Monday. That's the next time that we're having, that's the last full body task meeting. Today is the 17th. This is crazy, guys, but I'm just going to put it out here. Can you all commit to a meeting next week? Then that's if we want to get through the rest of these recommendations. And then if we don't want to get through them and vote on them for them to be elevated, we can at least have them as a part of the task force report and indicate that they had not been voted on or approved by the large task force so that the work does not get missed.
Yeah, I'm not able to meet next week. My calendar is packed next week, and I was assuming this was going to be the last meeting.
Me too.
Can we, I'm with you. Can we look at this and can we do it procedurally? Can we do a vote by email that in theory, I support these recommendations?
That's a really good question.
Do we have to have it open to the public?
Representative Johnson, my question to you.
Yes.
What, other than number one that was voted on by the subcommittee, the other, can we look at what the other areas that need to be voted on are? Okay, physical health, and what else?
That's it.
That's it, physical health.
Physical health?
That's it.
Okay.
They only have 3 on the physical health? Is that, are those only?
Yep.
Yeah.
Okay. And because the number 2 on the behavioral health is just discussion, so we can
comments. Yeah, it doesn't sound like there's anything we can vote on there.
And where is the person who represents physical health? Are they here?
Yeah, that's me. That came from us.
Okay. Would you like to go through these would you like to discuss these recommendations right now?
Yeah, sure thing. I'll try to do it very quickly.
Okay.
I hope there's not too much noise behind me. But basically, we were thinking about prevention. A lot of the healthcare system is just focused on treating illness, which is important, but also we're thinking about prevention. So along those lines, we're thinking about physical education for kids. Physical fitness is great for preventing illness, maintaining health. So one is recommend physical education providers in Delaware schools include activities for children to maintain a level of active, safe exercise at home after school while delivering educational material on healthy eating to support a healthy weight in children. So some examples of the activities, physical activities can include jump rope challenge, push-up squat challenge, etc. And then another aspect of prevention is basically screenings and helping people get diagnosed with, and so they can get treatment. So 2, provide targeted outreach and marketing to clinicians, healthcare centers, community partners, and patients on cancer screening, and utilize DHSS and DMRC to set up mobile clinics similar to COVID vaccination clinics to provide direct access to mammography and colorectal screening. provide targeted outreach and marketing to clinicians, healthcare centers, community partners, and patients on health screening, health activity, counseling, and education. Utilize DHSS and DMRC to set up mobile clinics, again, similar to COVID vaccination clinics, to provide direct access to healthcare screening, to include evaluation for healthy weight, high blood pressure, diabetic screening, and then it's cut off, but I have the rest, unless you, there we go. Healthy weight, high blood pressure, diabetic screening will offer options for primary care facilities directly to individuals. And then these are just some notes we put in down there, so I don't know if we really need those notes, but basically, this is inspired by what happened during COVID. The concept was set up rapidly during COVID outbreaks, and the vital need was immense. And it's also been done by Lieutenant Governor with Narcan mobile units on a smaller scale. So mobile units work; they're effective. Both of these were to address independent crisis. We have a similar challenge to address the African American community. Basically, the idea of all three of these, is that just like there's disparities in healthcare in the African American community with treatment. There's also disparities with prevention. That we're thinking the African American community, could use equal prevention services as well. So that's the idea.
Thank you for that. So you're definitely talking about access to these preventative screenings. I see that clinics, and then I see prevention. Number 1 with activities in the school?
Yeah. Yeah.
Okay. I saw Cassandra's hand was up, and I know she has to leave soon. So Cassandra, did you have any comments, questions?
Yeah, so in theory, I think these are all good. I need to be technical and specific about the reference to DMRC. DMRC is no longer called that. It is called Response DE. The name has been changed. And additionally, Response DE is activated under a state health operations emergency order. And there's very specific language in the code about how they can be used and when they can be activated. And it's tied to a state health operation purpose, which is a national disaster or, of course, a pandemic response. So the way this is written, the code doesn't really allow for Response DE to even be utilized in this way. And I'm not sure if it would be appropriate, but the theory of having partners or having access that could do mobile, I agree with, but I would like the DMRC references may need to come out.
Okay. You're absolutely right with the DMRC piece. Okay. And maybe that's something to explore, instead of utilizing them, maybe DHSS Public Health utilizes some of the community providers that are in some of those vulnerable areas that are already providing services to some of the most vulnerable populations, especially in the minority communities that already have created those trusting relationships with these communities, to partner with DHSS Public Health to provide these services.
Well, can we just say, for the sake of time, can we just say utilize DHSS to set up mobile clinics, strike and DMRC out of the conversation?
Or partners?
Yeah, maybe DHSS and other partners.
And partners.
And community partners.
There you go.
Community partners.
That in, I believe it's in
number 3 also, yeah.
And community partners.
And then I'm assuming we take out that subset A. Do we need to have that in there? The 3A? Was that just kind of a comment?
Well, you know what? Let's leave that though, because it may be good to discuss that in the main task force.
Okay. Right.
Yeah.
Absolutely. So that they'll have
Madam
the
Chair, I think
idea.
that Madam Chair, I think that with these edits, we can go back up to the part 2 of in the previous one above and change that to just comments. I'm sorry. Go up to the previous page, the previous section. Keep going. Right there where we say comments, notes, just take the number 2 off of there, where it says comments, notes.
No, go down.
No, go down. You went too far.
Right there. No,
comments, notes, just
right
take
there.
the 2 off.
Do we need to leave? Yeah.
Oh, you don't even have to worry about that because we're going to revise the whole.
Okay, all right. And I think then we're at a point where we could take a vote
Yeah, so I would like to go to a roll call to vote on the package that was presented from the Physical Health Research Group. And thank you, Matthew, for being here and presenting those recommendations. Chelsea, can you do a roll call, please?
Yes.
So can you tell us what are we voting on?
Yes, we are voting on the physical health package. For one, to recommend physical education providers in Delaware to do some preventative projects, such as working with kids on healthy eating, how to exercise at home, all the things surrounding exercise and maintaining in weight, basically putting that stuff in the schools. We're looking at number 2, which it says providing targeted outreach and marketing to clinicians, healthcare centers, community partners, and patients on cancer screenings, and utilizing DHSS and community partners to set up mobile clinics, especially in areas where there is not a lot of access. And then we're looking at number 3, which is provide targeted outreach and marketing to clinicians, healthcare centers, community partners, and patients on health screening, healthy activity, counseling, and education, and utilize, again, DHSS to partner with community partners to set up mobile clinics to provide direct access to healthcare screenings and include evaluations for healthy weight, high blood pressure, diabetic screening, and other options for primary care facilities. You know, all the things that apparently Black folks are high risk for.
Yeah, those two I give up. Number 1, I wonder, I mean, that's what they do now. Provide education, provide, is this physical education providers in the school, or is it in and out of the school?
It says that, it also says that maintain a level of active, safe exercise at home.
Yeah, I think the idea here is not just having the physical education in the schools, but also taking measures to encourage kids and incentivize kids to exercise and engage in physical activity at home as well.
At home, is it after school?
And after school, yeah.
I think it's a great idea.
Okay, let's get to a vote, please.
Yeah.
Yes, can we do a roll call, please?
Yes.
Did somebody make a motion?
No, we don't have to. Chelsea?
Okay. Nikisha Bailey. Colleen Davis.
Approve. Yep.
Thank you. Keith Hunt.
Yes.
Forrest Watson.
Yes.
Cassandra Coates Johnson.
Yes.
Deb Harrington.
Yes.
Simone Philpotts. Eleanor Kiesel.
Yes.
Carmen Jordan Cox.
Yes.
Ray Jones Avery. Kathy McGinnis.
Yes.
Lucretia Young.
Absolutely.
Representative Kendra Johnson.
Oh, yes.
Representative Melissa Minor Brown.
Should I think of something fancy to say? No.
Amen.
Thank you.
Hallelujah. Amen.
Amen. Good. Yes.
Okay, so we have gotten through these recommendations. This was our last meeting. I'm the best. I want to encourage everyone to join the African American Task Force meeting. Definitely, jump on, observe as we get through some of these recommendations to get through the final task force. And also remember that we did recommend the entity to be created that will, the racial equity consortium that will house the additional recommendations so that we don't lose those recommendations and we can continue on to get to do this great work.
Will we get a link to the larger meeting?
We could send out a link.
Mm-hmm.
I remember to do it. I know it's posted.
Okay. If it's posted, that's all right.
You mean I have nothing else to schedule? I don't have to open my calendar anymore? You're not
I know.
No, you don't. No, you don't.
You were walking a fine line now.
Karen,
having it.
Carmen, can you open up your calendar for us?
Yes, and all it says is I'm trying to find a vacation, preferably out of the country.
Take me with you. All right. If there are no more questions or comments, I would like to entertain a motion to.
I just want to say one thing. I just want to say, representing AARP and 189,000 members in this state, I'm coming from Pennsylvania. That's my background, raised in the capital city. I am really proud to see the work that you are doing. I just really am honored to be part of this team, and I try to bring my best thinking to it. And I'm, there's been a lot going on with, a lot in my life. So I'm glad to be back on board. But I want you to know that any support we can provide to you in this work, because I'm a lobbyist. We're a lobbyist. That's what AARP does. The work you're doing is important, and it is a tremendous, tremendous amount of work. And so thank you for everything that you're doing.
So let me just add some closing, and then I will make the motion and we will get out of here. Even though all of the members are not here, for those of you who are here with us this evening and all of the other members who've been with us throughout this very long ride, from the bottom of my heart, I say thank you. Thank you for your commitment to this work. Thank you for your time. Thank you for all the times that we talk stuff to death, because it was so important that we wanted to get it right. Like, we know that you have so many other things that you could be doing right now, and you could have been doing for the last year and a half, but you made this a commitment. You made the people of Delaware a commitment. And to that, I say thank you. Thank you, thank you, thank you.
Thank you. Thank you too for your leadership.
Yes, thank you.